I'm a geriatrician and I investigate frailty both in research and practice involving older patients with multiple myeloma. And one of the things we know quite well about frailty is that it is associated with worse outcomes in patients on standard treatments. However, knowing that doesn't necessarily inform what the optimal intensity of treatment we should be prescribing these patients in terms of the number of drugs. We're using up to 4 drugs now in multiple myeloma, the doses of each drug, and the duration and frequency of how long they should be on these treatments for. So it's a big question and one of the challenges, because we're often faced with, do the benefits in terms of more effective myeloma control actually outweigh the risk in terms of treatment toxicity, which we know is higher in frail patients. So the goal of this study was to actually take a look back in a real world population that's even frailer than the general populations that are included in the randomized controlled trials that evaluate benefits and harms of these novel treatments, and see whether their survival benefit is any different than the fit patients that we see in clinic. And moreover, to confirm whether that survival benefit is still true and held up. And the original seminal randomized controlled trial that proved that one of the more widely used triplets today, the bortezomib-lenalidomide-dexamethasone triplet, or VRD, they showed that there was a survival advantage over the doublet RD back in 2017. That was published, the seminal SWOG S0777 trial. But we wanted to actually look at, in our real world population, whether those results held up. So what we did was we went back and looked at all veterans, and this is the United States Veterans Affairs healthcare system, the closest thing we have in the U.S. to a nationally integrated healthcare system. And we were able to look at and identify, using a validated algorithm, all veterans who were initiated, newly diagnosed with multiple myeloma, who initiated treatment on either VRD or RD from the years 2004 up until 2020. And we were able to measure frailty in these veterans using an electronic frailty index. These are being used now in national healthcare systems like the UK. We've built one for our nationally integrated healthcare system in the US, the VA. And we've actually validated against clinician frailty assessments, including the IMWG FI, one of the main frailty scores that are used in myeloma. And what we found was that there's quite a bit of frailty. About half of veterans initiating treatment on these regimens are classified as frail, with about a quarter classified as moderate, severely frail, the highest level of frailty. And we were also able to look at a number of important covariates to account for in our analyses, things like disease stage, so trying to measure the aggressiveness of myeloma, other comorbidities, polypharmacy, healthcare utilization. A strength of our data set is we're able to actually capture all of those variables and to make sure that they're more or less balanced across the treatment groups, so that we're really making a direct comparison as much as possible in non-randomized studies of the treatment effects of VRD versus RD itself. And so we used what's called a propensity score and matched on myeloma stage and propensity score within each of the frailty categories. And again, that was the analytic approach we took to try to, as much as possible, mimic a randomized controlled trial and equally balance all the covariates to try to make sure that the patients were comparable across treatment arms within each frailty category. And we were able to more or less do that as well as we can with our retrospective study. And what we found was that we did confirm the mortality benefit associated with VRD over RD in the combined overall population. But what was surprising was actually the veterans with the highest level of frailty, the moderate severely frail veterans, they actually demonstrated the strongest evidence of a mortality reduction compared to the fit or mildly frail veterans. And that was demonstrated by our point estimate hazard ratios being further from the null or further away from one in sort of the statistical term. And so the fact that we observed that the greatest mortality reduction associated with VRD over RD occurred with the moderate severely frail veterans, we actually took a deeper dive and looked at what was contributing to their frailty. And so an advantage of our frailty index is we can look at all the deficits that are actually contributing to a patient or veteran's frailty. And we saw that as frailty increased, the myeloma-related deficits such as anemia, kidney disease, and bone disease, and also stage 3 myeloma was much more prevalent in the frail, moderate, severely frail veterans compared to the non-frail veterans. And we also know that compared to other studies that we've looked at in more general populations with the frailty index, that frailty was much more prevalent in the myeloma population than the general population compared to patients of similar age and other sort of health factors. So that told us that what's happening is probably myeloma is contributing a lot to these veterans' frailty. And as frailty increases, at least in our study, the myeloma-related frailty and its complications probably disproportionately increased relative to the non-myeloma or aging-related contributors of frailty, such as dementia or heart failure or other sort of aging-related conditions that often go along with multiple myeloma. And paired with our results of finding that in the moderate severely frail patients, the VRD or more intensive regimen was actually associated with an even greater mortality reduction. It told us that probably a lot of this frailty is due to myeloma, and that more effective or intensive treatment of the myeloma may actually be more effective treatment of the frailty itself. And there are other triplet and investigating even now quadruplet regimens that are being tested in again, non-representative trial populations. For instance, the triplet that is now sort of used and what we use usually first line, and at least in our practice, I co-manage with Dr. Nikhil Munshi, who's the president of IMS and presenting at this meeting as well, is actually daratumumab-Revlimid-dexamethasone. And there's, of course, a seminal trial by Dr. Thierry Facon and others in the society that have shown that is it's associated with the survival advantage over doublets. But this is counter to sort of the historical guidelines that recommend a doublet rather than a triplet in frail patients because of the premise that frail patients may not be able to tolerate the additional drug or the additional intensity. And our findings actually show that, in fact, frailty may be due to the myeloma, and more intensive treatment may be more effective for the frail patient, with the benefits actually outweighing the harms. And I say that with caution because I'm not saying we should go now start treating frail patients with transplant or CAR T or even the quad regimens that are now available, but I think we should consider carefully recommendations for these frail patients and use both the real world data and well-designed randomized controlled trials to try to answer what are the best intensity regimens in these patients. And those should inform the expert sort of consensus or recommendations for the optimal intensity to use in these patients.